All right, so we'll go ahead and get started. So thank you guys for coming out to today's talk. So before we introduce the speaker, just a note for those who are joining us online. If you guys can take a moment and please complete the evaluation, you should see a link to it there near the, I guess it's near the video screen. Okay, near the video box there. All right, so just to introduce our speaker here, Adit Mandawat, he completed his bachelor's in biomedical engineering from Georgia Tech prior to attending medical school at Case Western Reserve University. Following his internal medicine residency at Brigham and Women's Hospital, he joined Duke University Hospital and the DCRI, our beloved here, and is currently a fourth-year cardiology fellow with clinical interests in multimodal imaging and interventional cardiology. His research interests include the use of mobile technology to facilitate communication and the treatment of emergent medical conditions such as STEMI, durable and percutaneous mechanical support, and multivessel coronary artery disease. He has published 25 peer-reviewed articles in 3 book chapters. Please join me in welcoming Dr. Mandawat.
Thank you for that very kind introduction. Good morning, y'all. We're going to be talking about a topic today that is very near and dear to my heart, which is cardiac anatomy and physiology. Over the next 45 minutes, what I hope to do is make this relevant to you. The goal is not to turn you into anatomy professors or medical doctors, but rather to inform what you to do on a day-to-day basis and hopefully give you a preview of where I think the field is heading and what sort of trials you may be seeing down the pipeline. The other thing I want to do is give you a lingua franca so you can communicate effectively with the clinicians you work with and that we all talk on the same page. There's a joke within cardiology that you should never use a $5 word when you can use a $10 word. But if you find me doing that, please by all means raise your hand. You'll see the presentation is meant to be more of a show and tell. There are exactly 2 slides that have text, everything else is images. So by all means, if you have questions as we go along, just please let me know. Let's see if we can get this going. So I have 2 disclosures, none of which are relevant. I do have patents and equity in medical communication. As you've heard, it's one of my interests, but we will not be discussing any of that today. So this is one of the 2 slides, I promise, that has some text. I apologize for it being wordy. This is meant more for the people online. What I'm hoping to do is to describe to you where the heart lives within the body. It turns out that is actually not a trivial question. And then I also want to provide you with a conceptual framework how you can understand cardiac problems. Function or anatomy drives function. So I think if you have a better sense of anatomy, you can certainly understand how things go wrong within the body. And then you can also understand how we fix them. We're going to spend the last piece of this talk focusing on a topic that I love, which is contemporary devices in the management of cardiac disease, specifically interventional devices. So let's all start by agreeing that the heart is the most important organ in the body. You might say, Adi, you're totally biased. You're a cardiology fellow. Of course you think it's important. And I'd reply back and tell you to look at where it lives. For those of you who are NASCAR analogies or fans, on either side of the heart, there are these 2 wonderful side impact airbags that refer to the lungs, okay? In front of the heart, there's a roll cage that is called the ribs, and then inferior to the heart, or bottom below the heart, there's the diaphragm. So the heart is very, very well cushioned when it comes to trauma, which is why you don't see us spending a lot of time talking about that. That's not usually how the heart breaks. It takes a lot to hurt the heart, okay? There's 4 basic parts of the heart. There is muscle. There's certainly valves that control the flow of blood through the heart. There's 3 vessels we'll talk about, and that's what I'm going to spend the majority of my career on. And then there's certainly wires, which you may have dealt with when it comes to electrophysiology trials. So there's 4 basic chambers to the heart, and there's certainly vessels going in and out. I was telling you it's important that you understand the language, and we call the top chambers atria. Okay, there's one on both sides. There's the right and the left. To be very clear, is the patient's right and the patient's left, okay? It's not yours or mine. There's 2 chambers in the bottom, they're called the ventricles. Those are the real pumps of the heart, okay? There's the right and the left, and we'll talk about that. And then there's 2 big blood vessels that enter and leave the heart. One is called the aorta and the pulmonary trunk, okay? What I want to show you is the cardiology gang sign. For those of you who were here last year, you may remember this. But I'm going to have you all take your left fist, put it up, okay? That is the size of your left ventricle. We're then going to put our right hand on top, okay, just like this. That's your right ventricle, okay? So what you can see immediately is the left ventricle is much thicker than the right ventricle. And the right ventricle is anterior or in front of the left ventricle, okay? The clinical relevance of that is for stabbings, for example, in the chest. It's very rare to hurt the left ventricle. It's much more common to hurt the right ventricle, which is the chamber in front. Out of the right ventricle comes a blood vessel called the pulmonary artery. That's what basically takes deoxygenated blood to the lungs, okay? And then out of the left ventricle comes the aorta. So I'm going to have you all do this, and this is the cardiology gang sign again. This is how we all roll around in the hospital. I'm trying to remember what's relevant and what the immediate anatomy is like. So we're going to do that one more time. Left ventricle, right ventricle, PA, pulmonary artery, or aorta, okay? So that should give you the basic relationships, and I think it'll help you understand how things can go wrong within the heart. How does blood move through the heart? I think it's actually important to get a sense of what happens in the cardiac cycle. So blue in this diagram represents deoxygenated blood, and red is oxygenated blood. You all may remember this from Biology 101. But blood enters from the rest of the body into the right atrium. And we said again, the atria are the top chambers of the heart. They're reservoirs, okay? It then moves through the tricuspid valve, and we'll talk a little more about that, into the right ventricle, and then is ejected out the pulmonary artery. That's this structure that we're talking about right here, okay? Goes to both lungs and comes back oxygenated into the left ventricle, and then is ejected out of the left ventricle, okay, to the rest of the body. This happens billions and billions of times within your lifetime, and it's actually fascinating that more things don't go wrong, okay? We talked about the anatomy here. The valve in front is, the valve that supplies the pulmonary artery is what? It's the pulmonary valve, right? And the valve that is by the aorta, which is the structure back here, posterior, this is the aortic valve. And there's two valves on each side, the tricuspid's on the right, as we saw in the diagram before, and then the mitral's on the left. What I want to show you is what the heart looks like when it beats. And let's see if we can get this to work here. Okay, so we're there. So again, this chamber up here, the atria, is the reservoir of the heart. And you can see that with each cardiac cycle, it's filling and then emptying. Okay, that's the common theme here. Blood then goes into the right ventricle, is ejected out of the pulmonary artery, okay, and then makes its way back here to the left atrium, all right? It goes into the left ventricle, which I told you again is behind the heart, and then is ejected out of this big pipe called the aorta, all right? You all have any questions about that so far? Okay, perfect. The part of the heart that I'm going to spend the rest of my life on is the coronary arteries, okay? These are the fuel lines that fuel the engine, essentially. And the reality is for a 45-year-old male, there's about a 50-50 chance that you're going to end up with coronary artery disease. Okay, so it's something that we spend a fair amount of interest on. There's three basic coronary arteries, so I'm going to show you part 2 of the gang sign. This is our left ventricle again. Okay, you're going to take your middle finger and run it down the front of it. That's like this, just like this. Okay, so where your middle finger is what we call the left anterior descending artery. That's the widowmaker that you've colloquially heard about. That supplies the front of the heart and the majority of the left ventricle. Okay, the artery that is arcing back towards you like this, okay, that's the left circumflex, and the one that's feeding the right side is the right coronary artery. So I'm going to do that again. Left ventricle, okay. Middle finger goes down where your knuckles are, okay. That's your LAD, or your widowmaker. This is your circumflex, which is arcing back towards you, and then on the right side, that's your right coronary artery, okay. Well, this is a cardiac CT image of that, essentially. And what you can see is these are all three-dimensional structures. There's minor variability in all these arteries, but this is pretty much constant for most of you. All right. The last piece that I'm going to talk about are the wires within the heart. You all may have relatives or may have friends who've had pacemakers or ICDs before, okay? And what these are devices to help us try and fix the wires that are broken. The heartbeat starts in the top right chamber of the heart, called the SA node, okay? And it works its way down and then is distributed to both the left and right side of the heart. The actual cardiac impulse starts from the apex, the bottom piece of the heart, and kind of there's a ringing motion that happens to basically eject blood out, and that's all normal, okay? So I just want to recap here because I actually think if you get this, what we talked about so far, you can actually understand how the heart breaks fairly efficiently. Cardiology, as I like to say, is not rocket science, all right? But left ventricle, right ventricle, pulmonary artery, okay, and aorta. Those are kind of part one of the gang sign. And then for extra credit, it's the LAD, okay? Knuckles are basically where the LAD runs down, your middle finger is, okay? And the piece of the, that is curving towards you, that's your index finger, that's the circumflex, and the part that's going to the right, which is your ring finger, okay, is the right coronary artery. That's the basic anatomy for all these things. So I've told you essentially what the heart should like, but where do things go wrong? How can we use anatomy to understand what breaks? So the first piece that breaks, and you all have more than likely had friends or relatives who who've had blockages in the heart, is coronary artery disease. Very, very common, and it's mostly due to, there's a genetic component to it, but largely it's due to diet and environment, okay? It's due to plaque buildup within the arteries that happens over time, and it's something that we certainly intervene upon a fair amount in the middle of the night, okay? The risk factors, as you know, are smoking, diabetes, hypertension, hyperlipidemia, and a family history. I've listed the treatments not because I expect you to remember them or necessarily even know what they are, but to give you a sense of the scope of what you may be seeing in the course of your research. This is where the bulk up till now of cardiac spending has been largely, and where the thrust of cardiac research has been. That's slowly shifting to heart failure in probably the last 5 to 10 years, and we're going to spend some time talking about that, okay? So the way we fix these things is a cardiac catheterization. This is a somewhat older diagram, so it focuses on getting access through the femoral artery and working our way up the aorta. So I told you again, the aorta is the piece that's coming out of the left ventricle. It's like this, okay? We go backwards, we go retrograde. We'll take wires and catheters up the aorta, engage the ostia, or basically the beginnings of those coronary arteries, and then use wires, balloons, and stents, essentially, to push plaque out of the way and open up those arteries so you can have blood flow again. All right. What's pointed out here is the radial artery, okay? So if you'll feel your pulse here, this is your radial artery, okay? This is now where we are preferentially getting access. So Sunil Rao, in particular over the VA, has been fairly instrumental in pushing this. But the reason this matters is in the old days, so some of you may have had cardiac caths, remember sandbags, okay? After cardiac cath, lots of pressure down there, people lying flat for 6 to 8 hours. We don't do that anymore. We go through the radial artery. We use a basically inflatable balloon then to hold pressure, and we send people home the same day. All right. The risk of bleeding through that access site is much, much less. So that's the preferential site now for intervening upon cardiovascular disease. What this diagram is showing you is how we do that, and it's the story behind this is actually really, really neat. It's actually neater than the procedure. The procedure now has become routine in some sense. But the way this all started was there was a radiology medical student in Emory named Andreas Grunzig, and this was in the 1970s, and he was even crazier than most of the medical students are these days. There was nothing like an IRB back then, so he decided to take a needle, cannulate his femoral artery, okay, or I'm sorry, it was his brachial artery, which is the artery right here, and then take a wire up to his heart, run into the x-ray room, and snap pictures to prove that he could get a wire to his heart. Okay, that's how cardiac catheterization started, and it's unbelievable when you think about how it's progressed. Now, we don't do, it hasn't changed all that much anymore. I told you we use the radial artery again. We take a wire up to the heart, okay? We then use plastic tubes called catheters to engage the beginning of those arteries, and then we use coronary wires, essentially, to get past these lesions. These are very, very thin wires, about the size of a human hair, essentially, to sneak past these things at times. We'll then use balloons to push that plaque aside, and then we'll leave a metal scaffold in place called a stent. Okay. Chances are, if you've been here at the DCRI enough, you will deal with one, if not all, of these devices at some point during your career here. Okay. I wanted to show you what a cardiac catheterization looks like. It's a lot less high-tech than you might think. Okay. What you can see is we have a catheter up here in the upper right-hand corner. Okay. This is our tube that we use to inject dye through the arteries. What you can hopefully see, even maybe not understanding what you're seeing, is that this is not a smooth tube. There's a narrowing right here, okay, that we call a stenosis. And this is really what causes people chest pain and cardiac symptoms, such as shortness of breath. And that's what we use wires, balloons, and stents to intervene upon, okay? So for bonus points here, I'm going to ask you something. So looking at this diagram, hopefully what is obvious to you is that the right side of the heart is only supplied by one coronary artery, okay? That's the right coronary artery. The left side of the heart is supplied by the left circumflex artery as well as the LAD. Those are the two that are curving back, or the one that's curving back towards you as well as the one that's going down your knuckles. So if you had to guess on this angiogram, what side of the heart are we on? So what I'm asking you is, how many coronary arteries do you see? So two. Well, there's branches, so you might say three, but two largely. So we're on the left side of the heart, okay? This, how many do you see? How many major coronary arteries do you see? One, so we're on the right side of the heart. It's really, in some ways, that simple. There's lots of different views we get to basically highlight stenoses, but this is the foundation of what we do. Okay. We're gonna, yes, sir.
So when we heard the terminology left main,
Yes, sir.
is that primary artery before we branch off into the circumflex and the LAD?
Yep, you got it. You got it. Let's see if we can get that to play here, and I'll actually point that out to you. That's this little nubbin right here. Okay.
You couldn't hear the question.
The question was that when you hear the term left main, what does that mean? Okay. So I told you that the left side has two basic coronary arteries, the LAD, the widowmaker, as well as the circumflex. Okay. They both start from a common point called the left main artery. Okay. That's this little nubbin you see here, right by the catheter. So in this person, there's a very short left main. Other people have longer left mains. The reason that's clinically relevant is left main disease is generally, probably until about 2 years ago, was treated primarily by surgery. Okay, the thought was that it was maybe too risky to do with coronary artery disease, or with catheters and stents, because we'd block blood flow to the entire left side of the heart for minutes. What we now know is that in selected patients, we can do this all percutaneously. So we don't necessarily have to do this with open heart surgery. We can just do this through the radial artery or to the femoral artery, go up with wires and fix it. Okay. So right now, the class 1 indications for surgery, you'll hear this often over and over again. The reasons why people should absolutely go to surgery are if they have 3-vessel disease, meaning a blockage in all 3 vessels, okay? Or they have a 3-vessel disease equivalent, which some people consider to be left main disease, okay? We know that surgery is better for diabetics because their stents tend to, frankly, fail more often, okay? But in everyone else, it's a discussion to be had with your physician, which one's better. So there's still many, many trials coming down the pipe trying to figure this question out. Yes, sir.
Why does it look like some of the dye is escaping out of the arteries there?
Yeah, so the technique to do catheterization is we take the catheter up, engage that ostia, that hole, okay? And then we hand inject, most often dye, through that tube into the arteries. If there's a blockage at the ostia, meaning the most proximal portion where the catheter is engaged, some of that dye might reflex back, okay? So that person has a very slight blockage there. All right? Okay. All right. Any other questions about coronary disease? So long story short, 3 vessels, okay? 2 on the left, 1 on the right. If you have a disease in all 3, it probably makes sense to go to surgery. Otherwise, it's fairly reasonable to have a discussion about patient preference, okay? Diabetics tend to do better with surgery. Everyone else tends to do better with PCI, all right? We're going to switch gears and talk a little bit about heart failure and cardiomyopathy specifically. You'll hear the word cardiomyopathy tossed around, and what it means is a disease of the heart muscle itself, okay? as opposed to blockages in the arteries, as opposed to valvular disease, as to a problem with the electrical system. This is a disease of the muscle, okay? What you're seeing on the left side of the screen is what a normal heart looks like by cardiac MRI, okay? You can see, well, it's hopefully going to vigorously contract, but I'm not sure that this computer has enough memory to show you that. But what you can see is that heart here is squeezing in, and you can also see there's a twisting motion that goes around with it if you look very carefully, okay? That is what normal cardiac contraction looks like. Then on the right side of the screen, how do you guys think that's different? So one is certainly bigger. You can see it's what we call dilated, okay? And secondly, you can see that the contraction of this muscle right here, which is the left ventricle, is much less vigorous, okay? The other thing I'm going to point out here is I told you that the right ventricle is in front of the left ventricle, and you can see that here again, okay? The right ventricle is a lot thinner than the left ventricle, and you can see that here again, okay? But cardiomyopathy is becoming more and more common and is right now accounting for about 1/3 of all hospital admissions in the United States, okay? It is big money. So if any of y'all want to fix the budget, okay, fix our certainly debt, don't worry about the corporate tax rate, okay? Figure out how to fix heart failure and you will have solved the national budget crisis in about 3 years, okay? This is the sort of magnitude that we're talking about. For heart failure, the etiology is generally ischemic. This slide is a little bit older, so it says 75% of the time. We now know it's about 60 to 50% of the time. And non-ischemic, meaning not due to blockages within the fuel pipes, the 3 vessels, between 25 and now about 40% of the time. Again, I apologize for the wordiness, but what it's meant to show you is there's lots of reasons the heart muscle itself can break, okay? So how do we treat it? One is certainly we fix blockages, okay? I've told you about how we can use stents, how we can use balloons, how we can use wires to certainly fix coronary artery disease. That helps sometimes. It doesn't help all the time, but it helps sometimes. We can use medications. You guys have probably, I've been watching a lot more football than I probably should, and I keep seeing the Entresto commercial on and on, you know. Tomorrow. But the long story short is we have new medications that can certainly help. But the focus is now shifting to device therapy, okay, more or less. ICDs are what they sound like. You guys have probably heard about these before. They're defibrillators that are implanted within the chest. What they're meant to do is treat fast heart rhythms that are dangerous, called tachyarrhythmias. The new kid on the block is something called CRT, okay, which is cardiac resynchronization therapy. In about 25 to 30% of people who have cardiomyopathy, what happens is instead of the heart beating like this in sync, okay, this is what you want, it beats like this, okay? And that's because of a problem with the wires that develops, okay? So that leads to decreased cardiac output to the order of 25 to 30%, okay? So what we've come up with is that instead of just pacing one chamber, the right, which we've done traditionally, we now pace both to get them back in sync, okay? And that's called CRT. It's now a class 1 indication for anyone who has evidence of cardiac dysynchrony on their EKG. So we're putting a lot more of these in, and I think you'll be seeing a lot more of them. The other thing I want to point out that is different from even a year ago is a lot more of these devices are now MRI compatible, okay? MRI is becoming in some ways one of the dominant modalities to assess heart failure because it tells us a lot about what the etiology of that heart failure is, okay? So let's say you do all these things. You revascularize the person, you do medications, you put in an ICD and a CRT in, and that still fails. What do you do next, okay? And there's 3 options. Option number 1 is transplant. The biggest downside to transplant, okay, is that we have a fixed number of organs available. If you'll have to guess, where's the best place to get a transplant? So what state would you want to live in if you needed a heart? No, they're pretty healthy up there. No. Colorado, like you're never going to get a heart. No one has disease there. So it turns out it's Tennessee. There's a lot of Jack Daniels and there's no helmet law there. Okay. The other place is Texas. So most of those places can get a reasonable donor heart within 7 to 14 days. At Duke, we're sort of between the 21 to 2-month range for hearts. Okay, so that's the major limitation of transplant. So to address that, we're implanting more and more of these devices called LVADs, which are left ventricular assist devices. Colloquially, they're called heart pumps. Okay. This technology has been around since the 1970s, but really has come in its own right, maybe the last 2 or 3 years. And the way this works is I told you that blood moves from the right side. So let's just review this. Blood moves from the right side, okay, pulls in the right atrium, then gets into the right ventricle, is ejected to the lungs, okay, and then comes to the left side where it's ejected to the rest of the body, all right? So the way these work is what they're meaning to do is replace the left ventricle, which is the chamber in the bottom. So what we'll do is we'll surgically implant a pump, okay, that pulls blood from the apex, the kind of front part of the left ventricle, takes it through this device, which is called the HeartMate 2 in this case, which is basically like a propeller on a boat, okay? It spins the same way. And then ejects blood out the aorta to the rest of the body, okay? You can imagine these are not just implanted on the left side of the heart. They're also implanted on the right side where they're called RVADs, okay? But they're implanted largely for 2 purposes. One you'll hear about is called bridge to transplant, which is what it exactly sounds like. These are people who are too sick and who are dying, okay, and would not make it to their transplant. So this device is a way to get them there, all right. The other way you'll hear about, and I think was Dick Cheney is one of the people who got these LVADs, is what we call destination therapy, which is meaning your quality of life is so bad with your heart failure that we want to give you something to improve the quality of life, but we know that you are not a candidate for a transplant. Okay. Do you guys want to guess how much these devices cost? Takers? Anyone? Not quite that much. That's a lot. But if things go bad, they can certainly cost that much. So the average, the HeartMate 2, I think we get a discount for about $260,000. Okay. Its cousin is a little more expensive hardware, and now there's a HeartMate 3 coming out. So it's the size of most of our houses. These are big deals to put in, and they take, frankly, a lot of work, and we are very, very protective of our HeartMate patients. We try not to replace them because they cost a lot of money again. But the most common reason they need to be replaced is something called pump thrombosis. Blood cells, I think, thankfully, like to clot. Okay, so when you cut yourself, you're going to stop bleeding. The challenge is that the materials that all of these devices are made out of cause that clotting to happen in accelerated fashion. Okay, so what will happen is the pump itself will form a plug. It'll just clot or thrombose off. We don't have the equivalent of Drano. Such a thing does not exist for these devices. So we have to just take them out and put new ones in. Okay. The other major risk with these devices is stroke. You can imagine that if a clot forms and is ejected out of the aorta, these blood vessels up at the arch hole lead to the brain. So these all basically go to the brain. So it's not uncommon for VAD patients to have a stroke. All right. And then infection is a concern also. They're on blood thinners. Everyone's largely on Coumadin. Okay. The level of anticoagulation is dependent on, I think, certainly the pump, but then what their history has been. If they've had pump thrombosis in the past, obviously, we'll make the blood more thin. If they've had bleeding issues in the past, we'll make the blood less thin.
The folks who are getting these destination therapy, they're too sick for a transplant? Is that the issue, or they're not?
So in the United States, each institution sets criteria to who gets transplanted and who doesn't, because they're a scarce resource. Okay. Generally, if you're over the age of 70, it's not absolute, but generally, if you're the age of 70, you're not a transplant candidate. That's sort of the first easy cut. The second easy cut is that if you have right-sided failure or you have pulmonary hypertension, you may not be a candidate, okay, for a heart, because when we put a new heart in, when it gets exposed to those high pressures coming from the lungs, it'll just fail. Okay. And then the third reason is poor wound healing. So if you're very, very obese, you're very, very diabetic, we won't open the chest, or we'll try to avoid opening the chest as best as we can, and instead we'll put one of these in as non-invasively as we can. This is still open heart surgery to get one of these put in. All right? But you'll see more and more people, I think, walking around with these. Yes, ma'am.
So are transplants and these, are they a fix or are they just
There's no
buying
such thing as a
time?
fix, okay? What I tell people is when it comes to heart failure, you are largely trading one disease for another, okay? There is no panacea, unfortunately, for heart failure, all right? The best we can do is certainly open up blockages and hope that the heart goes back to normal. That happens occasionally in ischemic cardiomyopathy. But if there's another process going on, as there often is, that may not happen. And if that's the case, these are ways to provide patients with symptom relief. Okay? This is rapidly becoming a very, very large expense for Medicare. So I think the reason I'm spending time on this is you are going to see clinical trials come down the pipe. They're trying to figure out who's the best candidate for this, what the best device is, and certainly what the best medications they should be on. Okay? All right, any other questions? All right, I'm going to switch gears here again and talk about valvular disease. I told you there's 4 valves within the heart. On the right side, there's the tricuspid valve, which separates the top and the bottom chambers. There's the pulmonary valve, which separates the right ventricle from the pulmonary artery. And on the left side, there's the mitral valve, okay, which separates the top chamber from the bottom chamber on the left side, and the aortic valve, which again is right by the aorta. But it turns out that valvular disease, as you get older, or maybe even when you're young, is fairly common. We're going to focus on 2 that I think are the most common ones you're going to see. The first one is aortic stenosis. Okay, aortic stenosis is a narrowing of the valve that basically leads out of the left ventricle. Okay, the 2 most common causes are something called bicuspid aortic valve, which means that instead of having a kind of 3-leaf clover, okay, shape, you end up with more of an ellipsoid shape, and that causes degenerative disease. And then what we call senile or calcific aortic stenosis, which happens to people as they're older. All right. The common symptoms are chest pain, shortness of breath. People may faint. Okay. And in the past, to replace the aortic valve, what you had to do is open heart surgery. Okay, it'd be a full sternotomy where you could make an incision down here and you open up the heart. More and more, we're stepping away from that. We are now doing something that's called TAVR, which you may have heard about in the news, okay, which is aortic valve replacement through wires, catheters, and balloons. Okay. I'm going to show you a video here because, frankly, I can't do a better job than this. But we can certainly talk about the technique a little bit after. I love the jungle music, by the way. I'm not sure who made this, but so that's what calcific aortic stenosis looks like. You can see that the valve motion is fairly restricted. Okay. And what that restriction does is impair the total cardiac output, the amount of blood that can flow through the rest of the body. So we take a wire up through the aorta. Again, we're going retrograde or backwards. And then we're taking a balloon up. And we use this balloon to crush the old valve. We will literally crush it. Okay? So that's the old valve that's been crushed open now. So that valve is no longer functional. Okay? It's like there's no valve there at all now. Then we take a bigger sheath up. And you'll see they deploy the new valve with a balloon. And you can see the new valve is opening nicely. Okay? But this is becoming more and more common, and I think what you're going to see in the next 5 years is this is going to become the dominant strategy for replacing valves within the heart. Okay, it's a huge shift as far as things go, because previously, the problem was that calcific aortic stenosis happened in people who are old, who are bad candidates for surgery. So the morbidity and mortality from these procedures was not insignificant. Now what you're seeing is that we're doing this in people who are even moderate or even low risk, okay, for regular surgery, just because we think that this is probably going to become the dominant strategy moving forward. All right? You can imagine that we replace mitral valves the same way. At some point, we may start replacing tricuspid valves the same way. But this is, again, coming down the pipe, and you'll see more and more of this. Okay? And the last thing that I'm going to, or maybe the last two things I'm going to talk to you about, the last one. Yep. They're replaced with, so what you're seeing the valve made out of is a stent. Okay? That stent basically is self-expanding sometimes, or is balloon expanding other times, but what it does is prevent leak, meaning blood going the other direction. And then the valve itself is made out of pericardium from a pig or a cow, depending on which valve it is. All right? But again, pretty amazing. Jeff Gesa, one of the surgeons, was telling me he had a chance to go out to the factory in California that makes these things. And it is an extended family of, I think he said, Laotian women who sits and sews these things by hand in a microscope, right? Which is one of the more amazing things that he's seen apparently. But they're all related, and they all do work with such precision that they can't figure out how to make machines to replicate it with the same error rate. So they just hire from within that one family. All right, we're going to switch gears here and talk about mitral regurgitation. So stenosis, when you hear physicians talk about it, means that the valve isn't opening. Regurgitation means that the valve is opening too much and it's leaking now, okay? And it's very common as people get older for them to, or a percentage certainly, develop mitral regurgitation, okay? Which is bad because it's one of the causes that can certainly cause heart failure. In the past, again, to replace the mitral valve, we had to do open heart surgery to try and repair it or replace it. That has not been great for patients either. So, well, give me a second here with this ad. And I want to show you what, this is the TAVR video. So let me show you what MitraClip looks like. This is what we're using now to fix mitral regurgitation in select candidates who are not candidates for mitral valve repair by surgery.
The blue flow filling the left atrium illustrates severe mitral regurgitation or
So this is
MR.
blood going backwards, okay?
The percutaneous mitral repair system consists of catheters and the MitraClip device. The catheter is introduced over a guide wire that has been placed using standard techniques.
It's the same way, except in this case, what we're doing is instead of going backwards from the left side of the heart, we're going into the right side of the heart and then crossing over, okay? Remember I told you the mitral valve is on the left side of the heart. It's between the top and the bottom chamber, okay? But to get there, if we went through the aorta, there's a fairly good chance that we'd either shower clots, okay, or basically thrombose the device. So now what we're doing is we're going from the left side and puncturing across that divider between the top two chambers called the intraatrial septum.
Is used
So that's
to
what they're showing here.
gradually advance the guide into the left atrium.
So now we're in the left side.
The guide wire and dilator are removed. The clip is gradually introduced into the left atrium.
And then what this is, the easiest way to think about this is a fancy staple, okay?
The clip is precisely positioned above the leak in the valve.
You'll see the mitral valve leaflets aren't coming together. That's what's causing the leak. So they'll advance the clip past the leak in the leaflets, as you'll see here in a second.
Color ultrasound imaging identifies the severe MR illustrated here with blue flow. The clip is advanced into the left ventricle below the valve leaflets. The clip is retracted and closed to hold the leaflets together to reduce MR. If the MR reduction can be further improved, the leaflets are released and the clip re-advanced.
So hopefully I'll get the idea there, that instead of, again, doing surgery, what we're doing is using percutaneous techniques to deploy what amounts to a fancy staple to bring those valve leaflets together and reduce the amount of mitral regurgitation. Again, more to see here. There's an ongoing COAP trial that Duke is part of that is looking at using this to reduce the incidence of heart failure, okay? So some of you will certainly get involved with that. And then the last thing that I'm going to talk about is atrial fibrillation. So atrial fibrillation, we spend time really on muscle. We've talked about blockages in the arteries. We've talked about valves, but now I'm going to spend some time talking about the electrical system. Atrial fibrillation is the most common heart rhythm disturbance in the United States. Okay, what it is a chaotic beating of the atria. So instead of doing this, the atria is doing this. Okay, the reason that's important is because there's a propensity to form clots in the part of the left atrial that is not contracting the way it's supposed to, called the left atrial appendage, which is what this is over here. It's a little cauliflower-like structure that sticks out from the left side. Okay, that's the reason why patients on who have atrial fibrillation, you'll see we put them on blood thinners. This is what we care about more than anything else. Okay. In the past, the challenge with blood thinners is that you had to certainly get your INR monitored. Okay, and then which is basically see how thin your blood is and adjust the dose, and then you have to restrict what you eat. That's gone away with the new medications. We don't ask patients to do that anymore. We just give them a pill and take it twice a day, okay, or once a day, depending on what the pill is. But for a percentage of those people, they will develop bleeds, and a small percentage will develop major bleeds, okay, because their blood is thin, it just doesn't clot anymore. So how do we treat those patients? And the way we treat those patients is using something called the Watchman device, which is a parachute that we put to occlude the left atrium. Again, I told you that 95 to 96% of clots here form in this part. So we just simply separate it from the rest of the heart using this parachute-like device called the Watchman device. Okay? You'll again, I think, see more and more of this come out. There's about 1 million people in the United States who are candidate for this. Okay? There's been about 12,000 implants so far, but I think you're going to see a lot more of this come about. All right? So I'm just going to recap before we finish. I think what you need to know for cardiac anatomy certainly is that there's 4 chambers in the heart. Okay, we talked about how the top ones are called atria, and then the bottom ones are called ventricles. There's 4 valves in the heart. The 2 easiest to remember are the ones that are the aortic and the pulmonary, because they line up very well with the vessels. Okay, left ventricle, right ventricle, pulmonary artery, aorta. All right. The valve that you'll see most intervened upon is probably the aortic valve, and then the next one is the mitral valve. We talked about the 3 coronary blood flow vessels, the left anterior descending artery, okay, the circumflex, and the right coronary artery. And then I think the last thing we talked about is some of the new procedures and devices that are coming down the pipe. You're going to see a lot more LVADs. I promise you, when you're walking down the street, look closely in Durham, and you will see people walking around with what looks like a backpack. But if you look closely, they have 2 little holsters here that hold their batteries. Those are patients who have LVADs. Okay. The other devices you'll see are TAVR. Unfortunately, you can't tell by looking at someone whether they've had a TAVR or not. But I think a lot of people over 80 now, this is becoming the default way to fix valves. You'll see the MitraClip come down the pike, and then for people with atrial fibrillation who do not like anticoagulation or have a contraindication to it, you'll see the Watchman come about. But I think if you just remember this sort of basic anatomy, you can figure out why we're doing these things and hopefully have a better interaction with your clinicians. Okay? Do you have any questions I can answer? Yes, ma'am.
I'm curious about the indications for the Watchman device. Is that something that you see becoming at some point more desirable than?
It's going to become more common. It's not going to become, I think, more desirable. As I told you, any of these devices, there's no such thing as a free lunch. Okay, we are trying to essentially bring about a process that has less side effects than what the patient is experiencing now. So if people are doing well in anticoagulation, my sense is we just leave them on it. Okay. But this is meant for more people who have an active lifestyle. I have a patient who's a avid rock climber, okay, who doesn't want to take anticoagulation. This might be a good device for him, okay. Or someone who has had multiple bleeds on anticoagulation. This might be a good device for him, okay. But I think this is not first line, to be very clear, for most people with atrial fibrillation. This is meant for people who have other reasons not to take anticoagulation. Yeah. Other questions? Okay. All right. Well, thank you for your time. I appreciate it.